Okay, everybody, how you doing? This is KIN231 231, and this is going to be basically kind of an overview and a little bit of reflection on some of the things that we've talked about with cardiovascular endurance. So let me get myself out of the way here. Thus far, we've done a number of field tests, whether it's the YMCA step test, the 12-minute walk run. We've also done, for example, a more clinical assessment, which was the Austrian rhyming ergometer test. Both are valid, both have their place, and as a practitioner, you might find that you're in an environment that utilizes one more the other, which is very common to have maybe more field tests versus more clinical. You're kind of limited in terms of your ability to do testing if you only have two bikes versus a track where you can train everybody or work everybody on the track and then do your fitness testing at one time en masse, basically with the entire class or your entire team. But usually what you'll have is a combination of clinical tests or clinical assessments and field tests. And the big thing we're after with either one of them, we're trying to get a data point to help us obtain an estimation of VO2 max. And VO2 max itself is correlated to workload, meaning when you look at somebody's ability to perform these assessments, the better they perform on the assessments is tied to how high of a VO2 max they have. But the question becomes like, what the heck is VO2 max and who cares and why is it important to us and why is it important to the client? So if we take a moment, we have to actually go back to kind of the rudimentary part of this and go, okay, what the heck is VO2 max? And this is a great article. You can link out to it from here. And this article does a really good job of just succinctly saying VO2 max, it's the rate of oxygen your body is able to use during exercise. Pretty straightforward, pretty self-evident in terms of VO2 max. Now, VO2 max, if we take it a little bit further, they have an article further on in the article, they describe how you have this relationship between VO2 max and athletic performance, especially on the endurance side. And I would presume that our classmate who runs middle distance track probably has a pretty righteous VO2 max, to say the least. He's probably got a pretty really high VO2 max. But it's a pretty good predictor of knowing if somebody can perform and be able to have their body process oxygen and CO2 during intense exercise bouts. But it's not only for athletes, right? It's a way for us to determine a person's cardiovascular fitness, or are they right here, cardiorespiratory fitness. And we use it as a correlation to a person's heart and lung health. So VO2 max does have its place. So all the work we've done in class, number crunching and going through all these labs, has been a benefit to help us get a better understanding of our own VO2 max. So let's take a moment to really go into what it is. VO2 max is maximal oxygen uptake. It's the highest amount of oxygen that can be taken up, transported, and used in the body. So there's a couple limiting factors in there. One of which is your ability to even just suck in oxygen, have it go to the lungs, have it be able to go across the membrane to the blood, and then have the blood transported to the muscles, and then be transported, or if you will, across the membrane from the blood to the muscles to be able to be utilized at a muscular level. So there's a couple limiting factors that are built in here, but the entire process is related to a couple things, one of which is cardiac output, often written as Q, right here. So you have a Q with a little dot above it. That Q, when you see it in literature, is cardiac output. It's the ability to eject blood. So we talk about the squish side from the left ventricle side, where squish, and we talk about the blood pressure being higher at that point. That's S/D, that's the systole side. What you have is, and we've already shined a little bit of a light to this, is oxygenated blood leaves the heart via the left ventricle. It goes out to service the body. It is at that point where you have the squish. That is the point where you have the highest amount of pressure in the system, right there at the atria, excuse me. And it's the most oxygenated the blood will be. As it goes through and services the rest of the system and comes back to the to the right atrium, goes to the right atrium via the superior and inferior vena cava and enters the right atrium, that's where it is least oxygenated. The difference between those two is this. It is which was referred to as the A-VO2 difference. So it's a matter of how efficient our bodies are in terms of, as oxygen-rich blood leaves the heart, services the body, then comes back as oxygen depleted, not fully gone, as you'll see, but there's a difference between the oxygen in the blood when it leaves and the oxygen in the blood when it returns. That's referred to as A-VO2 difference, and that is, quite frankly, a measure of efficiency, the efficiency of the body to be able to extract blood or extract oxygen from the blood. So the way we evaluate VO2 max is through a graded exercise test, and we usually do this on a treadmill or like we saw on a Monarch bike, and we use these graded exercise tests to evaluate the amount of oxygen that is consumed. Now, we didn't do this in class because we don't have open circuit spirometry set up where you wear a mask and it measures the amount of oxygen you're actually sucking in, the amount of CO2 you're blowing off, to give us a baseline regarding the difference in oxygen in versus oxygen out. And it'll compare the oxygen in versus oxygen out and relative to the ambient air in the room, sidebar. But what ends up happening is we use these specialized tools to help us evaluate, or in a more field test setting like we'll be more exposed to as trainers and fitness professionals. When you're outside of the lab, it'll be more of like a non-clinical type of test where we use performance and evaluate that performance against norms to help us determine what a person's VO2 max might or might not be. So if we look at VO2 max, it's a pretty widely accepted measure for aerobic fitness, and we look at it in terms of how it correlates to the degree of physical conditioning, and look at it in terms of the higher the VO2 max are usually associated with lower cardiovascular disease. So this is very much like, you know, our negative correlation like we talk about in our 8+1 format when we're evaluating our case studies. The better or more fit a person is in the cardiovascular side, they have a higher VO2 max, they have a reduced risk of cardiovascular disease, morbidity overall, and different comorbidities related to the cardiovascular system. Now, resting VO2, and this is one of those things you kind of have to take with you. When we look at resting VO2, it is, excuse me, get myself out of the way here. It is estimated at 3.5 milliliters per kilogram per minute. So if you have somebody who weighs 50 kilograms, it's relative to that person. It's 3.5 milliliters per kilogram per minute. If a person weighs 75 kilograms, they will have a higher total amount. But the baseline ratio on that is 3.5 milliliters per kilogram per minute, commonly referred to as 1 MET, metabolic equivalent. And where this becomes important is, and you see this in literature, is when people talk about metabolic equivalence, it's a way to measure and evaluate work relative to the person on a kilogram basis. So a person can be 75 kilograms, 50 kilograms, 100 kilograms, but they're still at rest at 3.5 milliliters per kilogram per minute. I've said that 20 times, and there's a reason why I've said it 20 times, because you'll have to remember it somewhere else. But when you look at elite level athletes and they get to VO2 max, their VO2 max is off the charts. I mean, they can get up to 80 or even higher milliliters per kilogram per minute, especially in endurance athletes. For most of the people who come in, you know, they won't understand much higher than the 3.5, and 80 would just be a complete stretch for them. They would never be able to get to that point. But this gets to a point, you know, when we talk about training, the ability to actually work on and increase or improve the VO2 max for a person. And the book notes about 10 to 15% from baseline. And it can depend, right? It can depend how deconditioned the person is. It can depend in terms of your training. It can depend upon the environmental side of it. And the question becomes, when we look at this, the greater or greatest improvement will be seen in deconditioned individuals. And there's a relationship that also happens where as the VO2 max increases, there's a concurrent, if you will, ability to have greater cardiac output, squish, that's that Q with the dot above it, and then you have better efficiency in the system itself. So the A-VO2 difference, arteriovenous, as is written here, becomes better, meaning you have more oxygen going out and it's being utilized in the system. So when it comes back to the heart, you don't have as high a percentage of oxygen in the blood. The body just becomes more efficient. So here's a question for you then. If we look at this, we go through, and we have lower aerobically fit individuals that often experience greater percentage of VO2 max. And there's a reason for that. And you kind of have to start looking at stuff and go, okay, why? Why is it a deconditioned individual would show greater results. And to a certain degree, it's because the person who is deconditioned is starting at a baseline that is much different than an elite level athlete, or I should say elite level athlete way up here. A deconditioned person has a broader opportunity gap to work through, meaning they have greater potential to increase their VO2 max. The relationship that you see, it's not straight linear. It's actually more sesamoid, where it's like an S curve. And that sesamoid is this: you have the greater gap in terms of the front end opportunity to have greater increases in performance. But as you get more and more and more fit, or you become more and more proficient, you end up getting tighter and tighter and tighter to what is your actual biological VO2 max. You can't go any higher than you've been made. But through training, you get tighter and tighter and tighter to the gap. So the curve starts with a very, very big gap on the front end. But as you go and you start to work, that curve comes up and it gets tighter and tighter and tighter and tighter. Sorry about the blurriness. It gets tighter and tighter and tighter to your absolute capabilities. So what happens is that margin gets tighter and tighter. I would just throw this out here for future reference. Can you describe cardiac output? Q. All right. And then can you describe A-VO2 difference, as we've gone through these last couple slides? The difference between blood leaving the heart, blood coming back to the heart, and the oxygen that is in each. You can click out right to here to a link, and hopefully, yep, it's still active. You'll be able to go out to that. So when we look at testing protocols, they're generally submaximal for what we do in working with our athletes or our clients. But there's some presumptions we have to make, right? Heart rate measurements, they must be in a steady state. We have to evaluate them in steady state relative to one another. And then true maximal heart rate for a given age is the same for all clients. So 22-year-olds will all have the same maximal heart rate. 40-year-olds will have all the same maximal heart rate. And 60-year-olds will all have the same maximal heart rate. It's based upon age, as we've already seen in our class. The relationship between heart rate and work rate has to be strong, positive, and linear. That is to mean that as we increase the workload, the body responds with an increased heart rate in a linear fashion, in a very tightly correlated fashion. When we look at the last one here, mechanical efficiency, this is working on the presumption that when you take somebody through a graded exercise test and you do some type of testing with them, that there will be some mechanical efficiencies, or more accurately, deficiencies that you'll see with people who are deconditioned in terms of their movement patterns, in terms of how they're actually able to do anything on a bike or a treadmill, etc. So you may have to actually help them in terms of being able to navigate the equipment. For some people, getting on a bike or getting on a treadmill will not be the best of fit. You may have to use a Rockport Fitness walking test or a 12-minute walk-run test with your individual because they're just not comfortable doing anything but ground-based testing because they just don't have the functional capability to do it, meaning the motor understanding to do that activity. So when we look at steady state heart rate, as noted earlier in the first one, it's defined as 2 consecutive heart rate measurements that are within 5 beats per minute of each other. So for example, when we did our Austrian rhyming the other day, we took a measurement at minute 5, we took a measurement at minute 6, and for our participant, both were spot on. They were the same. I think it was 155 and 155. And you take the average of those two for that testing protocol. But they were within 5 beats of each other within a minute. So we know that that person was in a steady state at that point and at that workload. That's the other important part. So we use graded exercise tests for this purpose to evaluate between exercise and workload. We have to have a systematic and linear increase in the workload over time in a stair-step fashion. And we use data gathered from this to help us determine a person's VO2 max, whether it's direct or indirect through charts, nomograms, etc. There's a great article on this as well. Lastly, this is what the process looks like in terms of when we work with people. Oxygen gets dumped into the blood, goes to the heart, out of the heart, to the muscles. Muscles utilize the oxygen. CO2 goes into the muscles. But notice there's still some oxygen left. Comes back to the right atrium, goes to the lungs, gets serviced. Oxygenated blood hops back in, or oxygen hops back into the blood, gets serviced again. That's the process we're talking about, the efficiency of his process. So I'm going to go. I got about 5 seconds left. I hope this helped you guys, and I'm going to move on to the next Prezi.